Alright, so we talked in earlier chapters about the changes a woman's body goes through in preparation for pregnancy, labor, and delivery. In this chapter, we're going to discuss how her body now recovers and reverts back to a non-pregnant state. While most providers will tell a woman she can return to normal activities at 6 weeks, there are certain considerations that need to be made. If a woman has a traumatic delivery or a cesarean birth, the postpartum frame will really need to be longer. We also need to consider what she does in that 6-week period that might put her at risk for problems such as a postpartum hemorrhage. One of the prime reasons for a late postpartum hemorrhage is going to be infection. Now, not all infections will initiate, develop, and declare themselves in that first 6-week time period. So in consideration of these things, many providers are looking at the postpartum period and will extend that even up to 12 weeks. What we have to remember is she was pregnant for 9 months, so will everything be completely back to normal and at no risk in as little as 6 weeks. So keeping her uterus firm and contracted is the number one way to prevent a postpartum hemorrhage event, and it promotes involution, or the process by which the uterus returns to its non-pregnant state. Even though we say postpartum is 6 weeks, involution will typically complete in much less than that. Okay, so the uterus will get back down in less than 6 weeks. Once the baby's born, the fundus drops to about the level of the umbilicus, sitting plus or minus a finger breadth over or under. Involution will progress rapidly, approximately 1 centimeter each day, and by 2 weeks the uterus should not even be palpable through the abdomen. As we've talked about before, a uterus that does not contract down is at risk for hemorrhage, so subinvolution of the placental site poses a significant risk to our patient. Right now, know that a common cause of subinvolution is retained placental fragments and infection. We'll go into more detail about subinvolution itself when we get to chapter 23. So, thinking about involution of the uterus. If you look at picture A, it's important to identify when the uterus is misplaced and what's the cause of that. So if you know where the uterine fundus should be and it's higher than that, you got to ask yourself why. Commonly, if the fundus is higher than expected or deviated from midline, the cause is going to be a full bladder. Another cause of a distended uterus to consider is retained clot from her postpartum bleeding. In picture B, we see a uterus 2 hours after delivery, and in picture C, we are 2 days out from delivery, and in picture D, we are 4 days out. I mean, stop and look at the difference in picture B and picture D. I mean, that uterus has really shrunken down, yes? Well, just so you know, these images are all from the same person, okay? So you actually did get to see demonstrated just how quickly the uterus decreases in its size. And, I mean, for me, I think that's a pretty cool thing. Now, the uterus has a lot of work to do, because if it doesn't stay contracted, we've already talked about she's going to bleed, right? The number one cause of postpartum hemorrhage is uterine atony. Let me say that one more time. The number one cause of postpartum hemorrhage is uterine atony. Okay? So, how does this work? Well, you got to remember the uterus is very vascular, and it's going to hold about 400 milliliters of blood when it's in a relaxed state. Now, the blood vessels in the uterus traverse through the muscle and the fibers, and it's almost like a basket weave of muscle fiber and blood vessels. So if the uterus is clamped down, it's cutting off and compressing on those vessels. There's no circulation through the vessels, and so homeostasis is maintained. To help the uterus do its job, the body will release endogenous oxytocin from the posterior pituitary, and that will cause uterine contraction. Exogenous oxytocin in the form of pitocin also causes uterine contractions and is utilized to help maintain the homeostasis. You may notice the woman who breastfeeds, especially the first time, will complain almost like she feels she's going into labor again with the cramps and the pains that she experiences. The contractions after birth that promote involution are termed after pains. The woman who breastfeeds gets that surge of oxytocin when she nurses, so she may well experience strong and even painful contraction like pains when she nurses. So it is a good thing that these pains don't last forever, or the woman might be hard-pressed to continue breastfeeding if the after pains are very intense. If you have a new primipara, meaning this is her first para, she may not experience the same intensity of the after pain as the multipara because her uterine tone is better and the uterus doesn't have to clamp down quite as hard. Any uterus that has been overdistended, such as your multiparous mom or somebody with large babies or a twin gestation, those uteruses may experience more intense after pains as well. As we've discussed previously, the placental site has to involute and close off to prevent postpartum hemorrhage. The placental site takes a little bit longer to regenerate. This can take up to 6 weeks as compared to the rest of the endometrium, which regeneration is complete in a little over 2 weeks. Okay? The delayed placental site healing is done pretty much to prevent scarring of the attachment site. So that way you can have future implantations and future pregnancies attach into the endometrium. The discharge that flows out after having the baby isn't the same as menstrual blood. It's really a collection of serum, blood cells, tissues, clots, debris, that kind of stuff. As the postpartum recovery advances, so as time elapses, the color and the composition of that discharge will change. So lochia rubra indicating red, really only lasts 3 or 4 days before it starts transitioning to the lochia serosa. The serosa is also going to have the serum, the debris, but it's going to have, old blood mixed in with it. So it's going to change. The serosa rubra changes from the deeper red to a darker red and then kind of to a brown sludgy kind of stuff. It's going to last 3 to 4 weeks before it begins to lighten up in its transition to lochia alba, which is going to continue until she has her first period. Now, if the woman is breastfeeding, she may not have a period, so lochia may persist for up to about 6 weeks. If the woman experiences a foul smell to the lochia, or experiences fever, pain, abdominal tenderness of any kind with the lochia, that may be indicating developing endometritis or inflammation, infection in the endometrium. This is a woman who needs to be seen by her provider as soon as possible. Alright, it stands to reason that the cervix would be soft and malleable right after delivery, as it underwent a pretty intense change with effacement and dilation to completely disappear. The same way the uterus has to get back to normal, the cervix does as well. So over the 12 to 18 hours following delivery, the cervix is going to start changing back. It's going to become shortened. It's going to become firmer instead of soft, and it's going to start thickening up. So it will start looking the way the cervical shape looked before she went into labor. Because of the activity of labor and the dilation, the effacement, and really when you think about it, just the trauma that the uterus and the cervix goes through passing the fetus out. The cervix is going to look bruised, and it's just purplish bruised if you were able to visualize it, and it will have sustained multiple small tears or lacerations in the birth process. And you have to imagine that those little tears and lacerations become prime real estate for an infection to set up in the woman. While the cervix will regain its shape within the first 24 hours, so it becomes thicker, firm, kind of shortens back up to what it looks like, it's going to take a few days for it to close back up completely. About 2 to 3 days out from birth, the cervix is still going to be dilated 2 to 3 centimeters. And a week after delivery, it's still going to be dilated about 1 centimeter. Remember when we were talking about changes way back in the beginning of the semester, and we talked about the cervix, and we said women who have never had a baby, when you looked at their cervical os, it was a little circle. Hadn't changed. That's one way you could look at a woman and tell that she'd never had a baby. After she delivers a baby, the os, instead of being circular in shape, is going to be more slit-like in shape. So it's almost like the cervix has a little smiley face mouth on it. So the parous woman who is delivered will have a slit for the os. The nulliparous will have a circular opening for the os. Rugae are the ridges in the vaginal wall, and once estrogen balance gets restored after delivery, the rugae returns and the vaginal mucosa will start to thicken up, becomes a lot more moist, and is less irritable and friable. Once returning, the rugae will have more of a flattened appearance in the woman who has delivered as compared to the nulliparous woman who has not experienced the estrogen deprivation or the vaginal wall changes that are associated with childbirth. If a woman is breastfeeding or with any delay in the return of ovarian function and the estrogen release, sexual intercourse may be uncomfortable because remember that estrogen is what helps promote that vaginal lubrication and the vaginal moisture. So if she doesn't have the estrogen, she's still going to have the persistent vaginal dryness. If this is the case, you need to be able to talk to your patient about having intercourse and returning to sexual activity, and advise them to use a water-soluble lubricant to minimize the vaginal dryness and the discomfort until the estrogen has kicked back in and she is producing her own vaginal lubricants. Be sure to inspect the perineum for injury and recovery. The vaginal opening itself may be swollen and bruised, and stitches may be present if she had to have repair of a laceration or an episiotomy. You're going to look for signs and symptoms of infection the same as you would anywhere else. You're going to look for redness, tenderness, swelling, purulent discharge. While we expect a certain degree of an inflammatory response in her tissue after she has the baby, you're going to need to be able to identify when infection may be developing. So what is the normal expected inflammatory response versus what indicates an infection? Especially in the third trimester, a common pregnancy complaint for our patient would be vulvar, vaginal, or anal varicosities. As a result of the heaviness and the pressure, the fetus, the enlarging uterus, all the fluid, that all puts a lot of pressure on the pelvic floor and perineum, and so they get the varicosities. The really good news for mom is that these problems regress pretty quickly and should resolve during the 6-week postpartum period. It makes sense that once the placenta delivers, the placental hormones, their levels are going to drop pretty rapidly. Thinking back, remember that the placenta was responsible for maintaining estrogen and progesterone in pregnancy. So once the placenta delivers, those hormone levels will decrease rapidly, and they will reach their lowest level somewhere around a week after delivery. The low estrogen is associated with the postpartum diuresis of the extracellular fluid that the woman will experience, and with breast engorgement. Estrogen will begin to rise about 2 weeks after delivery, and the estrogen level of the non-breastfeeding woman is going to be higher than in the woman who is breastfeeding. Now, decreases in hormones such as the HCS, that's too big a word for me to say, so I say HCS, and the enzyme insulinase reverse the diabetogenic effect of pregnancy, so much that blood glucose levels in the immediate postpartum will be much lower, and the insulin needs for the insulin-dependent diabetic patient may drop off in association to that drop in the blood glucose. Ovulation can occur as early as 4 weeks in women who are not breastfeeding, and menstruation returns in about 4 to 6 weeks. So it could be possible that a woman would ovulate before she recognizes the first menses, because if she's not keeping up with how the lochia is, she may confuse a period for lochia or vice versa. If a woman is breastfeeding, she may not ovulate for up to 6 months, okay? And so she may not experience periods at all while breastfeeding. If you have a breastfeeding female, the onset of ovulation and menstruation will be affected by the duration and frequency of her breastfeeding, as it is the breastfeeding that regulates the estrogen component, and the estrogen component is associated with ovulation and menses. So a lot of times it goes back to that whole reproductive chapter we did. Women who are exclusively breastfeeding, no supplementation of any kind whatsoever, and don't go more than 4 hours between breastfeeds, they can theoretically, if the estrogen is suppressed, not ovulate, and therefore they're not going to get pregnant, so those women would use breastfeeding as a form of birth control. With society's work schedule and life schedule, it can be sometimes very, very hard to maintain that strict of a breastfeeding schedule, so it's not the best recommendation for breastfeeding to be used as birth control. Most women will still have the pregnancy look for the first few weeks after delivery, in part due to the relaxed state of the abdominal wall muscles. Remember we talked about earlier the potential for the diastasis recti hernia, where the rectus muscles separate. So obviously those muscles have had to be under a good bit of pressure and strain for a separation to occur. Well, to that end, the abdominal wall, the muscles can take up to 2 weeks before they start toning up. Now, a lot of women, when the abdominal muscles return to normal, that period of time and what it looks like after they come back to quote-unquote normal will be predetermined by the state the muscles were in to begin with. What was that person's exercise and activity level before? How toned were those muscles before they were put under that pressure? Sometimes it's just the good genes that they've got. What did heredity deal them? So what they were before is definitely going to influence what they were like after, and then what kind of effort do they put into the return to getting that muscle tone with the provider approval. Now, women will sweat a lot the first few nights after having the baby, as well as diurese, in order to get rid of all the extracellular fluid she put on during the pregnancy. The total amount of fluid she loses through sweat and diuresing will account for about 5 pounds of weight loss postpartum. As mentioned before in our lectures, having a full bladder can displace the uterus and interfere with the involution process. When you consider how much fluid she's getting rid of, then her bladder has a big potential for getting full and even overdistending. Therefore, diligent bladder management is going to be a key intervention in preventing postpartum hemorrhage. You also have to remember that her GI system may have undergone that natural cleanse to prepare for the labor and the delivery process, and then we kept her NPO for fluids for the hours preceding her birth. It should make sense that it's going to take a few days before her bowel movement and bowel activity resumes. Now, the colostrum, or liquid gold as we call it, is in the breast initially. I mean, she'll have the colostrum before she ever goes into labor. The breast milk will come in a few days after that. Rachel was born on a Saturday, and I think it was Thursday when my milk came in fully. Now, once the milk comes in, the breastfeeding mother may experience tenderness for a few days until she adjusts to the fullness of the breast, and she and the baby have settled into a nursing pattern and a pretty balanced supply and demand system. We don't give medicine to prevent milk from coming in anymore the way it was done years ago. I mean, when Mom had Cecil back in '73, she got some magic pill that theoretically kept her milk from coming in. So because we don't do that, all women who have babies are having the potential for breast engorgement because we can't stop the milk from coming in. If you have non-breastfeeding women, the engorgement will resolve spontaneously as long as the breasts aren't triggered to make more milk. Okay, the milk should resorb into the body. So to manage the discomfort for your non-breastfeeding women, advise them to wear a snug supportive bra, such as a sports bra. You can use ice packs, cold compresses, and mild analgesics for the discomfort. It's important teaching to remind her if she stimulates the breast and tries to relieve pressure by expressing milk, then she may initiate that supply and demand system and could potentiate the engorgement condition that she's experiencing. We know a woman will lose blood having a baby. We allow up to 500 milliliters of blood loss in a vag delivery and 1,000 milliliters of blood loss in a cesarean birth, and we'll still consider this a normal amount of blood loss. We can do that because of the hypervolemic state that she was in with the pregnancy. Now, through having the baby, bleeding, and diuresing, her blood volume returns to the normal non-pregnant levels generally by 6 months after having the baby. Her cardiac output will be up for a couple of days after delivery because of the increased stroke volume that she has, because she's still holding on to that extra circulating volume. We haven't diuresed it out quite yet. So cardiac output specifically is going to be up for a couple of days. Overall blood volume is going to hit back to a normal state about 6 months out. Well, one of the reasons we still see pregnancy after the first one is that most of the discomforts of pregnancy have pretty much gone away by 6 to 12 weeks. Neurologic issues such as the sciatic nerve discomfort and carpal tunnel syndrome, those discomforts will go away. If your mom is still experiencing headaches in the postpartum period, it's going to be really important to do a good detailed history of that complaint in order to identify possible complications. She could still be at risk in experiencing gestational hypertension or preeclampsia. She is still at risk for seizures even though she's had the baby. If there was preeclampsia before delivery, she still is at risk for eclampsia. She could be having spinal headaches. She could have migraines that need evaluation, or she could have other hypertension issues in general. Relaxin, the hormone that causes the joints to loosen up, cartilage to loosen up, soften up, relaxin's gone, so the joints will now stabilize and muscles are going to return to a toned state. However, the joints that were affected by the relaxin, such as your fingers, in your feet, may experience growth. Now, the growth isn't like your foot gets longer, okay, but her foot may be wider. So instead of a regular width, she may have to have a wider width to go over the toe joints. Her ring may need to be sized up, not because where it sits on her finger is any bigger, but it may not fit over her knuckle. It's important to know your mom's blood type, the ABO/RH, because if she's RH negative and the baby is RH positive, then she may need a shot of Rogam, and Rogam is the trade name, Rogam to prevent isoimmunization for future pregnancies. And we'll talk a lot more in detail about that in upcoming chapters. As for mom's skin, the mask of pregnancy regresses. So the chloasma or melasma, that's going to fade out. The linea nigra, it lightens somewhat, okay, but it's still going to be identifiable. But the darkening of the areola and the nipple area, that may persist. And that's one of the things that you can look at in a woman who has had a baby and one who has not. The areola and the nipple, the pigmentation is usually really, really light pink, but for women who have had babies, it's going to be darker. It's not going to be black, but it's generally going to be a darker color. Stretch marks on the skin are actually tears in the elastic of the skin. So they're not going to disappear, but instead of those, bright red tiger stripes, they're going to fade into silvery striations, and it may take up to a year before they completely fade out to where they're just a skin tone color. When a woman is pregnant, all of her hair follicles synchronize, and she usually is going to develop nice, full, thick hair. Okay? The fine hair that she develops in pregnancy is going to disappear. However, the coarse hair that she develops does not. And isn't that just the way it goes? We'd like to keep the finer stuff and get rid of the coarser stuff. And not only is that going to happen, but the way they all synchronize for growth, they're all going to synchronize for shedding. And when we get into postpartum, we'll talk about how a woman will actually undergo a pretty rapid hair loss. So that's it for Chapter 13. 9 months of compensatory changes reversed in about 6 to 12 weeks. The body's a pretty cool thing, isn't it? All right, so that's it. Any questions, bring them to class. Thanks.